Good morning, dear friends. This is Dr. Sachin. I'm gynec endoscopic surgeon in India. Presenting today the analysis of Dr. Sachin's criteria for adnexal torsion management. So before coming through this Dr. Sachin's criteria, we'll take an overview of some adnexal torsion cases and some common surgical approaches that are considered for its management. So basically, it's a torsion, it's a partial or complete rotation of ovarian vascular pedicle on its own axis, and it will cause obstruction to arterial inflow and venous outflow, leading to various complications. So, coming to the management of this, we'll have a look at some adnexal torsion cases and its a common management strategies. So this is the first case, 28-year severe pain, unmarried girl, and even she suggests of 5 centimeter ovarian cyst with a torsion. So what could be, may I ask you, what could be the management in this case? Out of this, is only detorsion or ovarian cystectomy, and whether to do ligament plication in such cases or no. This is the first one. Second case is 11-year-old premenstrual bilateral adnexal torsion. So here, what could be the management? Shall we be doing only detorsion and leaving alone while operating this patient? There is the rerotation 2 or 3 times just before or doing the surgery. So what could be the management? Shall we detort and leave it? Shall we detort and do ligament plication? And if ligament plication is to be done here, so what method of ligament plication is to be done here? Third case here, right adnexal torsion, obvious blackened necrosed ovary. So what is to be done? Detorsion and salpingoforectomy. And fourth case, this is a case of torsion due to PCOD. So what is to be done here? Detorsion alone. Shall we be doing PCOD drilling in such cases, or drilling and plication? So why Dr. Sachin's criteria at present? So at present there is no definite guidelines for the management of adnexal torsion. So subjective decision is involved. You might have been seen in these previous cases. Everyone's opinion might be different in such 4 cases. So there is always a subjectivity involved from surgeon to surgeon which treatment modalities to be used in such cases. And so this is an attempt to standardize the management protocol by following these guidelines. This is a small video shows, see, if you want to go to one place, it can be approached by many routes, but it cannot be standardized. Airplane travel cannot be standardized or compared with a bus travel. So this criteria is attempt to reach to one location by choosing the one option by everyone, so that the treatment modalities can be standardized. So what this criteria says, Dr. Sachin's criteria, if you are coming across a case of a torsion which is due to ovarian cyst and size of this ovarian cyst is 5 centimeter or more, then first do detorsion, and if size is more than 5 centimeter, do ovarian cystectomy. After the ovarian cystectomy is being done here, measure the uterovarian ligament length in such cases. If the uterovarian ligament length appears to be more than or equal to 5 centimeter, in such cases do ligament plication. The third, if you are coming across cases of a torsion in a premenstrual girl and in cases of a torsion in the recurrent cases, do use hot dog in bun technique for a uterovarian ligament plication. And if torsion is due to the PCOD, do detorsion, do PCOD drilling also, as it is a bulky ovary, more cortex, and do ligament plication in all the patients, and also give some ovarian suppression for 3 to 6 months depending on the sonographic finding after 3 months. So how do we objectively measure this length? See, this is a picture showing bipolar Bissinger. This is a standard equipment used by everyone across the world. This is a grasper and a bipolar. This is a Bissinger standard bipolar. It is opened across a measuring scale. So if Bissinger is opened, the distance between this is 2 centimeter, and if grasper is bowel grasper standard is opened, it's 3 centimeter. So this video shows how we are measuring. So by applying methylene blue to the tips of a Bissinger, would try to make a point on the uterovaran ligament or any tubular structure that can be measured objectively. So 2 plus 2, this is a 4 centimeter. So we objectively can come to know how this ligament or any tubular structure length can be measured in such cases. So that objectivity can be taken in these cases. So this is a video of detorsion and a cystectomy and plication. The similar case, 3 turns of a torsion, a fluid is seen, left-sided torsion. We have detorted this. As the cyst size is 5 centimeter shown on the sonography, 3 turns, and we resorted to doing the ovarian cystectomy. And we simultaneously measured the uterovaran ligament length, and we decrease the uterovaran length to normal of 1 to 2 centimeters so that recurrence can be prevented in basically unmarried. So now coming to the hot dog in bun technique. This technique we are following in cases of a premenarcheal girl and in cases of a recurrence of a torsion. So what is hot dog in bun technique? So if you are considering the hot dog in bun, hot dog you must be seeing there are 2 parts of a bun, and this is the patties come in between. So this is the uterovaran ligament. This is a round ligament. Tube is here. So we are going from uterovaran ligament here to round ligament, coming back from round ligament to uterovaran ligament, not posteriorly, so that tube can be free, fertility potential can be achieved here. This is called as a hot dog in bun technique. As a round ligament provides a tough support, so chances of recurrence is prevented here. We are doing it in a premenarcheal girl and in cases of a recurrent torsion. This is the final anteriorly, not on the round ligament. So it will prevent. Round ligament is fixed structure. The similar case, small girl, small uterus, bilateral torsion, obliterating the POD, 2 cysts, cystectomy done here. And see, while operating also, the cyst getting again and again torsed. So even if you are doing the detorsion and leaving alone, so after in post-operative period, she is highly likely that she will develop the recurrence again. So to prevent that, we are using hot dog in bun technique here. The uterovaran ligament plication likely to be difficult in such cases as uterovaran ligament length is small and it doesn't fit in our criteria also. So this criteria is based on study of 44 patients about torsion, which is operated by me and followed post-operatively for a period of 7 years. Though no case of recurrence is noted so far. This criteria would help to standard, and one patient is also got pregnant whose uterovaran ligament plication is done. So it will avoid the subjectivity, and this no fertility potential is not affected even after this. So coming to the age distribution, most of the patients were in the reproductive age group 10 to 40 years, 10 to 25 more, 50% of a patient. Right-sided torsion is more common as obvious in other studies. Coming to the treatment part, this salpingo-oophorectomy part is a bit higher in our study. What happens, so we are going to many places to operate in India. That's why the lack of and long duration to the referral increases this number of salpingo-oophorectomy. So those patients who are coming to us, we are trying to do salpingo-oophoropexy and detorsion in patient. A detorsion is being done if the ligament length is less than 5 centimeter. Salpingo-oophorectomy most common in 26 to 40 age group, most neglected, pain, all these things after birth. And the oophoropexy is done more common in the age group of younger age 10 to 25, and of these some patient of below the age of 15 years we have used hot dog in bun technique for the 4 patients here. Diagnosed size of cyst is more than 5 centimeter, of approximately 99% of a patient here, and uterovaran length ligament is also more than 5 centimeter in all the patients. This is again, so this is all about the criteria and analysis. Aim of this criteria is considered to be achieved if one ovary is saved and one recurrence is prevented everywhere. Thank you so much. Yes.
So I want to ask, when you do the bun and hot
Hot dog
dog technique, what shooter do you use? What shooter do you use?
Silk one number. Silk one number. Silk. Yeah, it's a non-absorbable suture. What happened? Personally, in my studies, initial 4 or 5 years, we are not having any recurrence of a torsion in a premenarchal girl. But there are 2 or 3 cases who have been operated by other surgeon using Vicryl number 1 PDS. They have got some chances of a torsion, and when relook laparoscopy, that suture was left out. So after since maybe 17, 18, we are shifted to using non-absorbable suture in premenarchal girl. One number muscle.
And where is the positions of the shooter? Is it proximal or distal?
No. 1 centimeter from the insertion of uterovanal ligament in the uterus, and 1 centimeter from the ovary. So that physiological length of this uterovanal ligament can be kept if sometimes even if she requires what is called as embryo, what is called for IVF treatment, embryo. Not,
egg retrieval.
yeah. Then at the adequate length and mobility of ovary can be kept it out.
Based on what evidence have you decided to choose 5 centimeters as a cutoff for cystectomy and for oophoplexy?
Cystectomy more than 5 centimeter, it's in the literature. Any cyst more than 5 centimeter gets torsion, so we have kept that criteria. Beyond 5 centimeter, almost all the patients of chances of torsion are so high. So arbitrarily we kept that criteria of a 5 centimeter to do cystectomy. Uterovanal ligament 5 centimeter criteria we have chosen as any structure, any physiological body structure. If it's stretched beyond 2.5 times, it has got some inherent weakness. Normal uterovanal ligament length is almost 2 to 3 centimeter. In average is 2.5 centimeter. So beyond 2 times means 5 centimeter if it's increased. So to reduce it to its normal level of 2 centimeter, we have chosen that 5 centimeter.
Do you ever consider interval cystectomy if you're worried about preserving the ovary? Sometimes after a torsion, the ovary is very hemorrhagic, and it's difficult to do a cystectomy without, getting good hemostasis. So do you ever detort and come back later for a cystectomy?
In our study, we have not yet done. We have done everything at one sitting only. One sitting only. Sometimes in some cases, if the bleeding is suspected, we have sutured the ovary. Normally we don't suture the ovary after cystectomy, but in some cases, if we are suspecting bleeding and hemorrhagic, then we may suture to make it as normal as possible.
Thanks.
In that cases.
Alright.
Okay, so
Last
one
question.
more. Do you have any experience of doing these cases? But we often found the cyst torsion is already neglected. Means when we do the surgery, the blood flow is already disrupted. It just become necrotic, like or purple. Do you, is this method can still be applied on that?
99% we try to preserve the ovary, and there are only 2 ovaries. Even if you know ovary is blackened, unless it's a auto amputated in that case, or it's a very much severe hemorrhage, severe hemioperitoneum, completely blackened ovary. Even if after we detort the ovary part, ovarian cyst, and we see even if some white structures, white patches appear on the ovary, we tried to save the ovary. We're not straight ahead proceeding to the salping of it, but we explain it to the patient. So sometimes what happen if infection or other chances, they may need a second relook laparoscopy within 48 hours. But otherwise we preserve.
Thank
Thank
you
you so much.